Everybody for your patience. Thanks for the invitation. Our objectives today, as you can see those, we're going to talk about ECMO volume and management, 6 key steps in building an ECMO program, consider the financial drivers in doing so, discuss personnel coverage model, key aspects of successful simulation in ECMO training, and discuss one successful reimbursement plan. What I do want to say at this point in time, as I was starting to say before, the years I started as a nurse, and anytime I'd walk into the CT ICU and see an ECMO patient, it takes a tremendous amount of time, talent, money to do this. But the reality is that ECMO typically cost a lot less than it does to do a year of chemotherapy, a year of hemodialysis, lung transplantation. So in the end, the quality adjusted life year for an ECMO patient is far more successful than it is for some of these other areas. So it can be quite beneficial from a financial standpoint. So this is not moving up here either, so I can't see what's up there. All right. Yeah, okay, so I really apologize. I'm probably going to be looking at what's up here because this is not matching what's up there. All right, so anyway, if we move along, what I want to talk about is what happened in the years related to ECMO. The bottom left-hand corner, actually, you can see the upslope in frequency of cases in around 2006, 2007. And that's fairly consistent. The question is, why did it happen? Frankly, I don't have an answer for that. What I can tell you is financially, it is a good moneymaker for hospitals. So that may have been some of it. Survival has slightly improved over the years. The cost per day has gone down from $12,000 to about $8,000 a day. However, the cost per patient being taken care of has gone up from $90,000 to $120,000. Most likely it's related to the fact that patients are staying in the hospital for longer periods of time. Here's another. This came out of HUP. I think this one's by Fenton, showing again the same thing. That increase in caseload, it happens in 2006 to 2007. The exact same trend. So their volume, they showed increase from 200 a year to 3,000 a year, and mostly in relation to post-cardiotomy and cardiogenic shock patients. And this is ELSO's last data from the January 2017 report. And you see the same increase. So if you're looking about right here, this is around 2006, and this is 2016 here. So that 10-year period, ELSO had an extra from 131 reporting centers to 305 reporting centers, with reported cases nearly tripling. So it's fairly consistent. Something happened in that period of time, and people now started to want to do a lot more ECMO cases. What's happening in terms of the survival to discharge and survival to transfer, it's stable to increasing, and it's falling in the same way that it has for year. The pulmonary patients do best, cardiac do a little worse, and the ECPR patients don't do quite as well overall. Dr. Bartlett, as we know, the father of ECMO, presented this paper, and he has shown very similar to, perhaps better than, previous discussions in terms of weaning from ECLS to hospital discharge with the adult patient. You can see these numbers here. What's really interesting about his is his prediction that people are going to move to more simplistic systems, number one, and that the ICU staff is going to probably be managing ECMO patients, and we're starting to see that now, and most of that is cost-driven. And lastly, that going into the future, we're going to see an increased frequency in use of ECMO, and certainly we've seen that. And what I want to point out here to you is, and let's see, we make sure this is, if this is going to work. Nope. It's nothing. Nope. That's not bringing those up. Anyway, the last item I want to show you up there, if you haven't read this article, it's from Perfusion in 2003 by Dr. Bartlett, and it was a prediction of perfusion in the year 2050. He is so far ahead of times. When you look through this list, just about everything is already happening on that list. And the last one is, that's not showing there, is percutaneous cannulation and emergency bypass. And in that particular paper, if you haven't, again, please do read it. He talks about a husband who has a massive MI. They're out on the street, and the paramedics come, and they put the patient on ECMO bypass in the ambulance. So that's the last item on there. And I would only tell you that these up here have already started. They're already in place. So there's no reason to believe he's years ahead of time. This article is by Gregorian, and it shows the 6 common steps in putting together an ECMO program. And you can see those steps up there. So I'm going to move along. What I found most interesting but important to this discussion is that financially it is something that you strongly need to consider from the beginning to the end. So I added that up there. In terms of planning, there's 3 phases. One is the steering group. It's your clinical and administrative leadership. And secondly is the needs assessment. And then the third part of that is to actually put together the program from a needs assessment. In terms of budget development, 3 phases of budget development is your direct cost, equipment, supplies, drugs, personnel, and purchase services, such as a perfusion company to come in and manage their ECMO program. Indirect costs related to utilities, insurance, ancillary services, and taxes. That's about 5%. And the last item up there is your fixed expenses, which is typically your facilities, administrative overhead. So of the 100% cost to develop an ECMO program, around 26% of it is indirect and direct costs. The remainder is related to areas like equipment, people, and supplies. And I'll start talking about those areas now. Program coordinators. Within our program, we use a perfusion director who is totally responsible for the program. We also had a lead person who is an ECMO coordinator. Their role is to make sure that the equipment is there, the supplies are there, the schedule is filled with people to take care of the patients. In our prime model at UPMC Presbyterian, we use perfusionists bedside all the time. At another model that we're responsible for, they use perfusionists and they're transitioning over to a nursing RT model. Next is specialty physicians. Within our organization, we have 2 leaders. We have a medical director that comes from the CT-ICU, and our surgical director is usually the chair of cardiac surgery as well as the VAD program. Specialty nurses, all of our nurses go through ECMO training. We go through a simulation process with them, so they're at bedside with a perfusion staff. And then the support staff is an important part of it. And this accounts for a large percent of the dollars spent in an ECMO program. Equipment cost, you can see those up here. And I put these 4 up because there were 4 that we looked at during a recent transition period that took place between 2014, 2015. And you can see Thortec Center Mag, McKay CardioHealth, McKay Rotaflow, and a Serin Revolution pump. We trialed the Revolution, we trialed the Rotaflow, and we ended up going with the Thortec and the McKay CardioHealth. It's pretty obvious they're the most expensive, but we have found in going with these particular devices that we have practically no change out in terms of pumps with the Center Mag pump. We use the Quadrox oxygenator, and within our program we have 3 CardioHelps and we have 6 Center Mags. The CardioHelps are primarily used for transport of patients. In addition to this, this goes down a little further and it shows cannulation items in there. So when you talk about supplies, these items that I typically look at in creating a budget. The next item I wanted to talk about are the options in terms of covering ECMO. There's essentially 2 that were presented in this particular article from the advisory board. One is to have a consolidated program. I've worked diligently in the last 6 years on standardizing and integrating our perfusion programs, and we manage about 14 heart hospitals. You can achieve such improved outcomes not only in terms of patient care, which of course is most important, but you can really begin to save dollars when you integrate and standardize. You have people going to hospitals that understand everything that's going on. Instead of buying tubing packs for 200 here and 300 there, you're buying $5,000 for the whole program. It really goes a long way. But in terms of ECMO, the characteristics of a consolidated program is you've got one centralized system. So at our place, it's Presbyterian Hospital, and all the ECMO patients go to the CTIC unit. We have Children's Hospital of UPMC Pittsburgh, and that's where all of the peds neonates go for ECMO. So within ours, we have the characteristics of having one physician group and one hospital. The equipment's in one place. The advantages are obvious. You've integrated and it's standardized, so you don't need to be going around looking for equipment and people to help you. The disadvantage is the people working in adults obviously aren't as attuned to taking care of other patients such as neonates and pediatric patients. The separate model utilizes multiple units. As an example, at our children's hospital, there are 3 units that will accept ECMO patients. And, you know, as a general rule, when it comes around to weekends and holidays, it becomes more difficult. They may have a patient in the pulmonary unit, in the cardiac unit, and in the transplant unit. And now you're needing to have equipment in each one of those units and have staff that can manage those patients all be available in multiple units. Whereas if you had a consolidated unit, it eliminates that particular issue. So a separate unit, the benefits to it though is the individuals working there understand the care of those particular patients a lot better. So if you're working with a neonate or a pediatric patient, that's a benefit. The disadvantages are pretty much as I've just explained to you. You've got people dispersed all around as well as equipment all over the place. In terms of developing a program, a strong recommendation I have is to classify patients so that you can determine what sort of ratio you need to work at. At our facility, we're able to watch 4 ECMO patients to 1 perfusionist. And that number will go up, obviously, over 4. We have 2 people there. Perhaps the busiest that we've ever had was the last H1N1. We had 13 patients, and we had 3 perfusionists watching those 13 patients, understanding that many of those patients were VV. They were very stable. And a strong recommendation is that you classify your patients. Class 1 would be somebody who needs attention, fresh out of the operating room, bleeding, cannulation problems, oxygenation problems, drug issues, changing inotropes. Class 2, the patient's a lot more stable. The perfusionist might be in-house, but not necessarily at bedside. And Class 3 would be a patients or one patient that you could watch from afar. In some cases, you could be observing these patients from a home port of some sort. Something else I wanted to bring up is licensure. At this point in time, I believe we have 21 states, and those states are defining who can or can't watch ECMO. When we were writing the bill in Pennsylvania, there was quite a concern about having just perfusionists responsible for it. So they widened that for other licensed PA clinicians, such as PAs, RNs, and RTs that could watch it, as long as they meet the ELSO guidelines. As you can see those there, 24 to 36 hours. In 36 hours of clinical mentoring. So that's something important if you're starting a program or just getting licensure. Keep in mind, well, you may want to hold that to yourself as a responsibility. At some point in time, you may need help from somebody else. So I thought I'd share that with you. In terms of cost, remember this is from FY16, and this is from Pittsburgh. Salaries in Pittsburgh tend to be a bit lower than they are in other pockets of America. So you can see the salaries on top, and these were the 4 most common staffing models that I found within the western Pennsylvania and through most of Pennsylvania. Option 1 is a pure perfusionist at the bedside, and if you'd add those up, numbers down on the bottom come to whatever that is, 120 something. And then option 2 would be having RN, RTPA with perfusion within 2 hours. And that number is lower, much lower. Option 3 is having a pure RN, RTPA. That number is equally fairly low. And the last is to have solo RNs, RTs, or PAs. And that's the lowest number up on the board. So there's a significant amount of spending based upon who you have sitting at the bedside. The perfusion model, as we all know. So what this ends up showing to you is in FY16, there were 81 patients done at Presbyterian Hospital. And I have, if you were building a program, purchasing the devices I talked to you about and staffing it with a pure perfusion model, these costs show up. So we spent on equipment $340,000, $990 on supplies, $1.450 million on personnel, training, ELSO. So if somebody can total that up real quick. But what you see is it's fairly expensive. I believe it comes out to about 1.4, let's see, 2.5 million. So it's pretty significant investment. And in year 2, of course, you don't need to get the equipment again. The question then becomes is, do you get your money back from something like this? And I'll show you our financials over a 5-year period a little further down the line. In terms of implementing, the next step is success and sustainability of the program. It's important for education and training. First thing you want to do is assess the knowledge level of the people you're working with. In terms of training them, you're going to use simulation and, so that you can control crisis management. The third is credentialing requirements and knowledge of the policies, procedure, equipment, supplies, and personnel. And then also has a slew of guidelines, 2 guidelines that you can use, as well as the Red Book. And then there are training programs. So what we did is we put in place a simulation center, and we have a school of perfusion that we've had since 1973, trained over 500 perfusionists. Simulation center twofold. One for the School of Perfusion. We started it 3 years ago. And what we found is there's a tremendous demand for ECMO education around the country, and it's something I'll touch upon here in just a little bit. So the educational opportunities that we bring to the table on a regular basis, this is something we're doing all the time with our program, is a monthly sim session. We put it out on SharePoint, and at least 2 or 3 programs per month are on there. They're typically on Tuesday, which is a slow surgical day, and we invite all of our perfusionists from all around to come in, and we hold simulation sessions, and they can vary. We can be having an update on the cardio health, priming, changing out, walking ECMO. We have an annual continuing education ECMO program. We offer internal and external adult training sessions. Those occur in May as well as in October. Monthly ECMO M&M meetings. These are with the physicians. We started this process. We created the agenda. And we were very pleased to see that over time, we now have about 13 physicians that are showing up for these. And they're now an active participant of what we put together. We're a gold status ELSO center. We invite guest lecturers. We publish. We've got a strong quality management program. What are the last 2 items on there? Yeah, training courses and then transport. Our transport program is pretty extensive. Stat Medevac, I don't know if you're familiar with them, it's the largest transport company in the country. It has a presence across Pennsylvania and other states. Last year we transported 19 patients, and all of these patients came into our system, and that's a distinct benefit to us. Oh, thank you so much. To our organization. So what we see is you then become more of a center of excellence and you get more referrals. Oh, nice. This is great. So why simulation? New equipment training is the obvious, and that's where we started first and foremost. And the opportunity to trial new equipment before you actually use it on a patient is important. Develop new practices. So anything that we're going to do new goes to the Sim Center first, whether that be trying new devices or new protocols. We replicate infrequent events, so ECMO crisis management takes place in there, changing out devices whenever you need to do that. We practice with everybody, and they get signed off for annual competencies while doing that. ECMO simulation. Somebody mentioned yesterday, how do you get these things? We now have 3 ECMO simulators, and we go through biosimulation. So this is the Califia system, so it's high fidelity. And we got those through the foundation at a couple of our hospitals. So what we did is we wrote a grant and we sent it in. And they were more excited than we were to get the money to give us the money. And why? Because they're always looking to improve patient safety, improve patient care, and have people happy with where they're spending their money that they bring into the foundation. So these are the devices that we've been using for ECMO simulation. We also, again, through the foundation, got a perfusion simulator. So we now have 2 of those. And again, it's probably a wealthy foundation, but they've been quite helpful to us. So if anybody's looking to do it, you know, I'll send you the grant application and just try it. It's a good way to make some money. What we found out when we started to do ECMO simulation programs is there were a lot of physicians that were interested in cannulation. So what we did is we created what we now call Mike-akin, because the guy who created this is Mike, one of our perfusionists, and he spent about $200, and we now have 6 of these devils that we cannulated, and we opened them up, put in plumbing, and the real catch was adding realism. So what Mike did is Mike's an avid hunter, so he went out and he bought ballistic gel. The thing you see on TV where they shoot a bullet and the bullet goes in. Well, he used this ballistic gel. He took a Penrose drain, he put it inside of it, we pressurized it, and you look at it on an echo, you thought you were absolutely looking at a patient's circulation. So it's pretty cool. And the next step was to actually cover up Mike-akin, and it's not that clear, but it almost looks real. And every one of the physicians who have come to the program want to see and this mannequin and also cannulate. So 3 or 4 people might come up, and it's just like you're cannulating a patient. And they thread their cannulas up, and they use the echo machine to do it. It works out quite well. Our simulation course offers all of these. We have all of these items shared with them at the courses. And it goes from basic, and we use all participants. We've had RNs, RTs, physicians, surgeons. We utilize routine practice, competencies, new device use, cannulation, walking. We show transportation, ground transportation, air transportation, crisis management, quality management. There's something else on there I can't see. So we'll just move on. So again, the 2 programs are in May and October, and they're quite comprehensive. One that we take on the road, we call it boot camp, and that course is customized by the individual who wants the course. So they'll tell us we got 62 people to train, and we want to really focus on crisis management, and we'll build the course. We put everything into a crate about the size of a Volkswagen, and we ship it around the country. We could literally do these every other week. That's how many people are out there. So if you're looking for another way to financially support your program, this is a great opportunity for you. Data collection is extremely important. The lead ECMO person is responsible for that in our organization. Most of the programs, the quality programs that we do, we run through our own IRB at Presby. We have that dedicated manager, and the evaluations that we've done to date are related to multiple different areas. That is all shared with those physicians at the monthly M&Ms. We have an ECMO EMR. It's a homegrown system using what we have as PeriApp, and the selected performance indicators vary month to month. Here's a sample of clinical, trying a new device, changing out an oxygenator, frequency of allogeneic transfusion in different kinds of patients, and distal perfusion cannulation. That was a recent issue that we were having, so we went through checking multiple units, applied to the IRB as a quality project, and ended up what we thought was a good solution. From a financial standpoint, capturing all patients within our catchment basin, and transferring patients, and last is highest reimbursement at the lowest cost. A recent evaluation that we did on a greater scope was when we moved from 4 devices to 2 devices, and that was Biomedicus, the Syrin unit, CardioHelp, Rotaflow, and the CentraMag device. The evaluation went quite well, and we ended up with CardioHelp for transport and CentraMag for bedside care. If we transport somebody in that's on CardioHelp, we will not obviously switch that over, but if somebody is on a different system, when we pick them up, we always ask if they'd want them to switch over to the CardioHelp. If not, we'll transport them on whatever they're on. And the results of that is, as you can see there, disposable cost was reduced 23% in that quarter. No reported events, fewer interventions on ECMO, meaning less times that we were breaking into the system. Simplicity and routine improved for all the perfusionists, for the nursing staff, improved safety for our patients. So when it comes to reimbursement, I think there's 5 key questions one wants to ask themselves, and they are listed here, I hope. Yep. What was the total number of patients referred for or admitted because of ECMO? So you get those numbers. How many were turned away and why? How many of these patients were treated with ECMO? For those admitted, what was the total hospital bill per patient? Taking those all together, what you find is that you're able to, and reimbursement is the last item there. You're really able to focus in on how many patients you're getting, how much money you're going to make on these patients. And where does the reimbursement come from? If not familiar with this, it comes from a DRG code. The most common DRG code is 003. It's in competition in terms of maximizing reimbursement with transplant and other DRGs. And our coding people will let us know what they want to do with that. And then there are some outliers like length of stay and cost outliers related to timing, discharge disposition, and payer mix. For physicians, it's CPT codes. If not familiar with how reimbursement works for most DRG codes, it's pretty simplistic. As an example, in Western Pennsylvania at Presby, we have a large residency program, and we're in an area with a lower wage index, so you get a relative weight, which our relative weight is $6,300, and then the DRG code is 17.6369. So you would multiply the DRG code for ECMO times the relative weight, and that's what we would get under a normal circumstance for an ECMO patient within a set of guidelines. That will change based on length of stay and whether you had the patient. So the geometric length of stay, and also known as a second one down there is the arithmetic length of stay. So you add those up, and you'll find out what you're going to get in terms of reimbursement. In terms of maximizing reimbursement, this is what we have found. We identify ECMO procedures from the start. So as soon as somebody gets put on ECMO, the message goes out to 2 coders, and we have the same people that are coding the patient all the time. And that really has helped standardize the process. A dedicated team that understands coding guidelines, understanding of carrier-specific agreement and policies, including Medicare and Medicaid, observe prior authorization process and referral guidelines, observe case and disease management protocols. Documentation must be appropriate and submit electronically as soon as possible. Common submission errors are related to incomplete claim forms, lack of adherence to authorization, and coding errors. And maximization of reimbursement can take place through comorbidities, length of stay, and a higher cost to provide that service. Well, this one's really out. I'm gonna need to help you here. Here's our case mix index. So from 2012 to FY16, our fiscal year is July 1 to June 30. You can see years ago, like in 12, we were more often coding toward transplant than if you look, as you come down to 16, in 16, 2% of the patients were coded to transplant. What that's telling me is we're getting a better reimbursement from ECMO code 003 itself. In terms of payer mix, Medicare on top, Medicaid, and then commercial, and you can see the trend taking place there. Allegheny County, where UPMC is located, has one of the more elderly populations in the country. The Pew data shows that 20% of our population is 65 years or older. So in 16, we had 29% Medicare, 25% Medicaid, and 46% commercial. The other source of revenue is from physician CPT codes, and they're listed up there before you, and you can get reimbursement for things like cannulation the first 24 hours in the ICU, the next 24 hours, and then critical care first hour and per hour after that. Reimbursement is typically, as you can see it over there, I believe it comes out to about 30% of that, no, 26% of the total amount. On the bottom are CPT codes for the critical care first hour and the additional hour. And typical coverage for physician CPT codes, the charges submitted, it was $50,000, and you get about 26% of that, or around $13,000. And this is showing our average contribution margin, which is in the center there, right there. So in the end, this is what we're making per patient. That's a pretty substantial amount of money. So when you look at that, I think that's one of the reasons that in 2006, 2007, we started to see this grow, and we're seeing it continue to grow. Monday morning ideas, like what are the takeaways? Make sure your computer works before you get here. Involve finance team from start to finish. Build a transport program, regional referral center. You'll become a regional referral center. Simplify and standardize ECMO systems. Consolidate service delivery. That's the best staffing model from my standpoint. Regular quality and clinical practice reviews. Simulation center with training. Comprehensive data management. ECMO M&M meeting. And join ASAIO. And I believe that's it. Oh, this is probably the best part of what we do. On the left-hand side is Megan, 90 days on ECMO, cystic fibrosis, double lung transplant candidate. She is, how old is she? Did I have that on the? She's pretty young. She was in her early 20s, but she did survive the time on ECMO and had a double lung transplant and sent that a few days before her wedding. And then Sarah is on the right with her baby. She was 8 months pregnant, came into our women's hospital, and went into ARDS, and they intubated her, took her to the operating room, saved the baby. We transported her over to Presby, and they both went home at the same time 8 weeks later. So, good stories. I apologize for this. This was not my intention. So I think that's it. Thank you. And if you want any of this stuff, if you need it, if you want to talk about it, just let me know. You know, after all of this, I feel like I've cheated you somewhat. So